It's great.
Okay, so good morning, everyone. I am Jane Hauser. I am the Director of Marketing and Outreach here at NESCA. Thank you for joining us for this morning's webinar on early signs of autism spectrum disorders in toddlers and preschoolers. I am joined by Renee Marchant, who is one of our pediatric neuropsychologists at NESCA, and she will walk us through the presentation this morning and have a Q&A at the end. Regarding the Q&A, please do feel free to put any kind of questions that you have into the Q&A section down the bottom of your screen. You can also put it in the chat if you'd like, and we will do a live Q&A session at the end of the presentation. So thank you so much for joining us. And with that, I will turn it over to Dr. Marchant.
Hi, everyone. Thank you all for joining. To learn more about early signs of autism spectrum disorder, particularly in young children. So focusing today on toddlers, preschoolers, and having some discussion and understanding of the appropriate methods for evaluating a possible autism spectrum disorder. I look at this presentation as kind of an important overview of what parents, educators, advocates, clinicians may advocate for and may look for in seeking an evaluation to determine if autism spectrum disorder is part of their child's profile and way of learning. So I appreciate you all being here, and I'm going to give you kind of an overview of our plan for today, and then we'll jump right in. As Jane said, my goal is to share some information with PowerPoint and then have some time at the end for any questions related to the presentation or in general questions you have about autism in young children during our time. So we are going to start with going over the red flags for a possible autism spectrum disorder in young children. We are also then going to discuss the gold standard methods and planning and procedures that we would use for assessing autism spectrum disorder in young children. I'm also going to discuss some of the implications and the role of cultural factors, which I'll speak more about in the diagnosis of autism spectrum disorder, or ASD, as well as treatment. And we'll end with some overview of some resources and in my work, areas of intervention, therapy, services that I may recommend a family consider for children who may have a diagnosis of autism, for children who may show some signs and symptoms. And then we'll end with Q&A. So I wanted to start with the DSM-5, our Diagnostic Manual that guides diagnostic decisions and the important tool that clinicians and evaluators use for diagnosing, looking at the specific definition of autism spectrum disorder in writing and what we know from the research and what guide we should be using when looking at that diagnosis. Now, ASD as a diagnosis is an umbrella term, meaning that there's a saying kind of in the field of if you meet one child with autism spectrum disorder, you've met one child with autism spectrum disorder. As we know that all children who may have a diagnosis and those who don't are all different, have all different learning styles, all different strengths and areas of weakness. And autism spectrum disorder can be an umbrella term for understanding some of the challenges that children may face as a result of this difference, as well as some of the strengths that we would see with this profile. In our manual, the definition centers around two main areas of functioning that we want to assess in children and understand based on their developmental age, based on what we expect for a toddler versus a preschooler versus an elementary school student versus a middle school student versus a high school student. Are they demonstrating deficits or challenges in social communication and social interaction across multiple contexts? And secondly, are they exhibiting restricted or repetitive patterns of behavior, interests, or activities? This domain that we assess in looking at the possibility of autism spectrum disorders. Also includes patterns of behaviors like poor reaction to transitions, sensory sensitivities, insistence on sameness, or kind of routines and rituals. When we look at the diagnosis, it's critical that a diagnosis of autism is provided when a child demonstrates these challenges within the early developmental period. So particularly with autism spectrum disorder, we know that these signs and symptoms emerge early because it is a brain-based difference or disorder. In the research, there's a global time frame, though that can differ, but generally we think of symptoms emerging between 12 to 24 months, considering that the early developmental period, for looking at these two domains: social interaction, social communication, and restricted repetitive patterns of behavior. So it's critical as an evaluator to, especially with older children, while we're focusing on the young children today, to also assess those early years and understand the early years and their skills at that time. I also want to include an important framework for understanding autism spectrum disorder. I just described the DSM criteria that evaluators in the research we use for capturing this neurodevelopmental diagnosis that can produce challenges in social communication, restricted behavior and interests, repetitive behaviors. And as the field has progressed, and as we are learning more about the diagnosis of autism spectrum disorder, as well as other clinical diagnoses, ADHD, dyslexia, other learning disabilities, we're coming to a point in our research and in our understanding of appreciating neurodiversity as a critical concept to understanding that children with autism spectrum disorder, for example, learn differently, think differently. It's a difference in how their brain works and how they think. A way that we have pathologized and that we have diagnoses for, because we do see, and I see children who have challenges that we need to intervene around and address and build skills for. At the same time, we want to value that all children, diagnosis or not, have strengths based on how they learn and how their brain is wired differently. I think, and I talk about the diagnosis of autism spectrum disorder with toddlers, preschoolers, adults. It's a way of learning, a way of thinking, and a way of interacting with the world that we want to understand and we want to value. I also want to provide some information at this juncture about the diagnosis of autism spectrum disorder and context. We have our broader, we think about what's happening in the child's brain, how they're processing information, and also what's in a child's environment and how does that interact with their functioning or their behavior. And what we know in our research across both in the United States as well as international research, looking at countries across the globe, is that autism spectrum disorder is a brain-based difference or diagnosis, a neurodevelopmental diagnosis or difference that affects every person and social network very differently and impacts people of all racial, ethnic, and socioeconomic backgrounds. We also know that, particularly with young children, while there has been important movements, both from kind of a more broad, thinking about early detection movements that have emerged from kind of a government level or from the CDC, as well as from associations like pediatric associations, we have done a better job of advocating for early detection for children who are young as compared to when they're old. However, we still see that there are structural inequities in society that limit access to diagnosis and treatment for some populations. This is true, speaking not just for autism spectrum disorder, but other areas of need. For example, children who may be bilingual or have multilingual experiences, children who may have families who are experiencing multiple stressors, poverty, homelessness, There's a lower rate of diagnosis in children who may have those contextual factors as compared to children who are not experiencing those contexts and factors in their development. So we see race, ethnicity, language, income being barriers potentially for diagnosis. Gender has also become a more understood potential factor in limiting diagnosis, particularly for young girls. We know that girls have a lower rate of diagnosis than boys. We are recognizing in the research on girls who have diagnoses of autism that their profile, their way of approaching the world, their challenges can look very different than what we have historically understood for what autism spectrum disorder looks like. And there is important, helpful, I think, progress and trajectories we're seeing with more research and understanding, particularly for girls, and how to, catch some red flags early on to provide intervention and support. I also think about, as I mentioned, language. Immigrant, bilingual, multilingual children are diagnosed later. There is kind of a common myth that bilingualism can impact language delay or produce language delay in children, when we know in the research that that is inaccurate. And so that is one of the factors, though not at all the only factor that can limit diagnosis for bilingual or multilingual children early on in development. And, we have, broader, if we think of, your family's values versus another family's values, your, cultural context, what your family of origin, rules and values are, that alone can have impact on education or understanding about autism spectrum disorder. Is there stigma associated with an autism spectrum disorder diagnosis in your family or culture? That can be also a potential factor that influences children's access to services and diagnosis. So with that context in mind, I want to talk about why is early diagnosis important. When we think of brain development, just in the research for how the brain develops over time from birth up through young adulthood and beyond, there is more time and more opportunity for growth and development. Your brain is highly plastic. As we know, children have very flexible, growing brains that can learn skills, develop skills that they are learning and experiencing in the world. If we think of play, when young children are playing, they're building connections in their brain, learning how to socialize, learning how to communicate and use language. Neuroplasticity really matters. So it's going to be a lot easier to work with a child who's in kindergarten on learning skills, like you're learning to read, you're also learning how to read social cues, than if you're working with a 22-year-old who has had years and experiences of not having those specific skills taught to them around nonverbal cues and cue reading. We also see with early diagnosis, as compared to late diagnosis of autism spectrum disorder, that there are less comorbidity, or there's less comorbidity with other conditions like anxiety and depression. Whereas if I see a child who may be a teenager and has, being evaluated with me, and I say, wow, we have this different way of approaching the world, this diagnosis that's been missed, oftentimes at that juncture, because of some of the challenges that they're experiencing and feelings of difference, we would also expect there to be higher levels of anxiety or low self-esteem or depression. And so we want to catch this brain difference early so we can understand it. The family, the school, all the treatment professionals working with a child understand this difference and way of approaching the world in order to prevent that potential comorbidity. Lastly, we know that a child's first relationships, whatever that looks like for a child, their parent, their grandparent, an early intervention provider that they work with very closely since they were young or born, that first relationships, those early years, can have particular impact on your emotion regulation skills, your social skills. And so having a diagnosis to understand these are areas that we want to focus on during these critical years, this critical time frame, is so important for making sure that students, as they age, learn skills, build skills. And first relationships are a critical resiliency factor for being able to show progress and to show development in skills. I also, in my experience in working with toddlers particularly, and kind of that emergent, that shift from early intervention into preschool, with having, let's say, an evaluation with me or another provider who conducts evaluations, it's an early time frame to have a diagnosis or diagnostic navigator, someone to kind of walk with you through understanding your child and the diagnosis and making sense of it together. Developing a relationship early with that person in a child's life as compared to later down the road. Similar to, some children who may have the opportunity to have the same pediatrician since birth, so that can, in my experience, be very helpful for tracking changes, tracking growth, and supporting families through different stages of development with an early diagnosis in early childhood. So in looking at the diagnosis of autism spectrum disorder and the importance of early detection, we have clear recommendations outside of neuropsychology from our American Academy and Association of Pediatrics, who not only recommend early screenings, which over the last 15 years has become really advanced and better at early detection and red flags with some of the questionnaires that parents might be asked when they go for a well child visit or when they visit their pediatrician. Not only are these early screenings more accessible and more widely used in pediatric offices, but it is also true that pediatricians, other providers that work with infants, toddlers, within a pediatric setting or in a doctor's office, are also aware that follow-up diagnostic assessments that are more thorough and more in-depth focused on this question, if we are seeing some red flags, is recommended as compared to the wait and see approach. And in my experience, the wait and see approach carries more risks than receiving evaluation and investigating this possibility earlier rather than later. So I want to go over a couple red flags that are clearly in our research and understanding of the diagnosis for autism spectrum disorder in young children. I want to also note that this is not comprehensive. And as I said, autism spectrum disorder is an umbrella term, meaning that there are different variations in how those domains show up for a child. So I might go over this list, and there might be parts of what I'm saying that really match and fit a child that you know or someone that you work with, and there might be others that do not fit and are not a helpful way of describing their functioning. One of the clear markers of autism spectrum disorder, and that we want to consider a possibility of autism spectrum disorder, is if there's family history of the diagnosis. We do know that there's a high genetic loading for autism spectrum disorder, and that, for example, children of parents who have diagnoses of autism spectrum disorder are more likely to have that diagnosis as compared to children who do not have parents who have those diagnoses. Other important red flags in the literature are limited use of body language or gestures. Now, for little children, compared to me talking with my hands in this webinar, is pointing to objects of interest or showing you things with their hands and getting close to you and wanting to share and show an item, a play item of interest. Also things like clapping and following along with nursery rhymes and songs, and using your body to show emotion, to share information with others. Children with autism can have challenges with those skills. Inconsistent eye contact, which can look like not using your eyes to share and to show information that you're interested in or that you like, not sustaining your focus interpersonally when you're one-on-one with your caregiver, when you're playing together, when you're engaged. Any loss of language is a red flag potentially for a diagnosis. So children who may have, let's say 100 vocabulary words roughly, and then, 4 months later, those vocabulary words they're not using anymore. They're not using their language to describe, dog and cookie and things that they were saying prior are not being used and seem to have been lost or disappeared. Differences in pronoun use. So some children with diagnosis of autism spectrum disorder may confuse or use me instead of I. They may use their first name instead of a pronoun when speaking. Jimmy likes cookies for when you're trying to request, or Jimmy's trying to request that he wants a cookie. Also some evidence that some mixing of pronouns between he and she as well. There can be differences in voice tone and kind of how children use their speech to communicate affect or emotion, inconsistent response to name or responding to being called. Sticky attention, which is in the literature is a description. So sticky attention is kind of having that strong focus on an object of interest, an object that you're really focusing on, that you're trying to explore and understand, that can be repetitive. It also may not be repetitive or not practiced regularly, but may be observable in how children interact with toys and explore them. And repetitive or obsessive or routines in play, either with caregivers, educators, or alone. So maybe having a specific way of interacting with their toys that happens over and over again and repetitively, stacking objects, lining objects in a row, or lining them up in a row, organizing objects into certain categories, arranging them in a certain way. Others include differences or different responses to pretend or social games. These are things in young children, toddlers and preschoolers. It can be talking on the phone, peekaboo, responding to a nursery rhyme that you're listening to and focused on, let's say, even on the iPad or the computer together. Not feeling interested in those activities, having a poor reaction to those activities, feeling sensitive to maybe some of the sounds of those activities, inflexible play, getting stuck and rigid with other children, repeating words and phrases or creating new words and phrases that are different than what we would expect for that child's language skills, whether they're English speaking, Spanish speaking, bilingual, multilingual, repeating words or creating new novel words and phrases. Poor reactions to changes or transitions, motor behaviors, hand flapping, spinning, rocking, and some sensory hypersensitivity or hyposensitivity. So that can look like seeking stimuli more so than what we would expect for a child at that age. It can look like aversiveness to hugs or physical contact, aversiveness or discomfort with textures. I have a low pain tolerance or high pain tolerance, sensory sensitivities or sensory processing challenges can be a part of a diagnosis of autism spectrum disorder when we look at the constellation of particular symptoms a child may have. I wanted to just briefly show kind of some other red flags that are associated with autism spectrum disorder. And I use this as a different slide purposely because as we read through this list, we see these bullet points can mean many things and can be because that child has a diagnosis of autism and can also not. It can also be, let's say, age appropriate to context in certain circumstances, like being emotionally sensitive, vulnerable to temper tantrums. 2-year-olds show that, right? We would expect that, and we would want to see that as part of their development. Poor eating, sleeping, and toileting routines. That is also an experience for children, regardless of if they have a diagnosis or not. Aggression, poor attention, high energy level, impulsivity. So we see that one of the reasons we need to pursue a diagnosis evaluation or an evaluation of the potential diagnosis is that it could be very age typical in what we would expect for that child, these symptoms we're seeing. We could also be seeing signs and symptoms of something different that is an autism spectrum disorder. Nevertheless, these are red flags that could indicate we want to investigate this potential diagnosis. One of our, as evaluators, kind of standards for making assessment planning and how we carry out an assessment, how to address treatment needs of children with autism spectrum disorders, are guided by the National Research Council. And they produce guidelines for how evaluators should be evaluating children who may have a possible diagnosis, and some of the treatment recommendations that we know from research based on years of looking at responsiveness to treatment for children across different ages. And I include kind of their 3 tenets, which are ensuring that an evaluator looks at multiple areas of functioning, that an evaluator understands that variability in skills in a child's development and performance is very common for children who don't have diagnoses of autism spectrum disorder, as well as those who do. The use of a developmental perspective when assessing behavior and synthesizing results. So that being an important tenet in terms of evaluating what do we expect for a 2-year-old in terms of their eye contact, their use of gestures, their use of language with their caregiver compared to what we would expect for a kindergartner, a first grader, or a middle schooler. Clearly, you know, in my work and evaluators speak to the accurate diagnosis of autism being complex with some of the factors that we've talked about. One being that there's variable behaviors. There's kind of this umbrella term that means that the diagnosis can look differently from one person to the next. Also, that context and environment has and can increase symptoms of autism spectrum disorder, meaning that a child who has that diagnosis may have more severe symptoms when they're stressed or when they're experiencing a situation that feels out of their control or overwhelming. We also know that some of the symptoms of autism spectrum disorder can happen for children who are stressed and don't have that diagnosis. So this is an important kind of variation that an evaluator would want to consider and evaluate. And you know, the criteria, as we've talked about being an umbrella term, leaves much to clinician discretion. And so I often say that it can be easier to rule in or say, yeah, from the checklist of red flags, my child looks like he might have autism spectrum disorder, when really that demands a more thorough evaluation and assessment, because it's easier to rule in those red flags and symptoms based on what we know about development and what we know about the diagnosis being an umbrella and being broad, than to rule it out and really understand for that child, is this appropriate and accurate? Is this a red flag for something else? Is this a red flag that's expected based on their own development and what we would expect for their age? I include this graph from the CDC. I like this graph because it looks at different domains of functioning that would be assessed in an evaluation for autism spectrum disorders. So things like intelligence, social interaction, communication skills, behaviors, sensory sensitivities, motor skills. And the purple dots kind of show us that, you know, if we took one child and we kind of mapped where they were on these different lines, we would see that you could have a variety of different kind of visuals for each child you would see. So, you know, this child, for example, in social interaction kind of lands more in the end of the spectrum, being not so interested in others, where another child on the spectrum, that purple dot may lie really close to having a variety of friendships for their age. And I do think that this is an important framework for understanding the diagnosis. We've definitely shown some growth and understanding of what the labels around high functioning and low functioning can mean for children, and trying to have a broader, more accurate picture of what that means and what a diagnosis of autism means. And this is a helpful way that I talk to families about of understanding your child, right? Is that it's not just this dichotomous low functioning, high functioning. It's my child is really strong and has strengths in, their friendships and their use of verbal communication. And my child also alternatively has challenges or is struggling with nonverbal communication and how sensitive they are to certain sounds that they hear or certain textures when they wear clothes. And so I think that's an important framework that we're getting better at describing the diagnosis, understanding what profiles look like. Okay, so next, I'm going to move to a different screen, and we're going to go to this section of our presentation. So looking at the actual evaluation of autism spectrum disorder, and then we'll end with resources and treatment and questions, our Q&A period. So this is a list of when I see a child either within a comprehensive neuropsychological evaluation or a child that I am evaluating within the ASD diagnostic clinic here at NESCA that is specifically targeted at looking at young children and early detection of the diagnosis. These are the domains that I must assess and that I must use in making my decision as an evaluator of, does this child meet criteria for autism or not? Developmental history is critical. Looking at that child's development pre-coming into your office to now. I will also say, in my experience amidst our pandemic and where we are today, something that's been very important is evaluating what this child was like before the pandemic. What were their social skills like? What were their behaviors like compared to now, and compared to, let's say, the first period of emergency closures, of either a preschool, daycare, etc. Direct observation is also necessary and critical in order to make a diagnosis. Very important with the tasks that we have to evaluate this diagnosis, and in the evaluation itself, to create a social world or an experience for a child that at toddler's age, you're not sitting down and having a bunch of pencil and paper tasks. That makes no sense. But we are engaging that child in specific play-based assessments that have been created and have been researched as ways to observe potential symptoms of autism spectrum disorder. And it's critical that that direct observation of a child's skills, outside of just reading about a child and reading reports of what this child looks like, well, that's part one. Part two is also direct observation. Caregiver and collateral report. So you also, outside of your interaction with that child and my interaction with the child, I want to understand who that child is outside of my office. And this is very important for understanding ASD as a possible diagnosis for young children. I am an unfamiliar person. I am someone that may be new and fearful for some children, for others not. For other, very comfort and relaxed in an evaluation setting. I want to understand if this child is showing me social skills that aren't deployed as successfully because they're stressed or because this is a new environment. We also want to use the gold standard measures, which I'll go over briefly after this slide, and what measures would be used in an evaluation to compare that child's behavior and performance on these tasks compared to children who have in the research the diagnosis and children who do not. Also, critically for looking at autism spectrum disorder, for toddlers and preschoolers, we also want to have an early assessment of a child's early problem-solving cognitive skills and their kind of real-life skills in the office and outside of the office. So, early cognitive skills, when we think of kids in this age, play, interaction, using language, figuring out how things work, finding objects and, putting colors together, putting, puzzles together, right? All these play activities, for example, are building logic, strategy, problem solving. Those are early cognitive skills. If children have difficulties in that area, it is possible that some of the symptoms that would look like autism spectrum disorder may be because their cognitive development is behind same age peers or same age toddlers. And so an evaluator, it's critical to make sure you have a baseline of those early cognitive skills to make a valid assessment. So these are two of the widely used gold standard measures for autism spectrum disorder. I use both in practice. I frequently use both in all of my evaluations, though it is completely appropriate and acceptable to use one or the other. In how I formulate my evaluations, I think that there is value to both of these gold standard measures. And so I often use both, though not always, but most of the time. So the ADOS-2 is a standardized measure of looking at autism spectrum disorder that looks at aspects of communication, social interaction, play skills, behaviors, and the ADOS can be administered to children ages 12 months all the way to adulthood. There's different modules or different activities that would map on to a child based on their developmental stage and age. The CARS-2 is a different type of assessment. It is a rating scale, meaning that there are a bunch of questions that I am asked and that I have to fill out on a piece of paper as an evaluator. Questions about sensory sensitivities, use of nonverbal skills like eye contact and gestures, use of social conversation or verbal language skills, any presence of motor behaviors or repetitive behaviors. And as an evaluator, you rate a child based on direct observation of that child. And with the CARS, you also use history and incorporate history or collateral report in making your diagnosis and your ratings. This standardized measure, that is a gold standard measure, has been very useful during the pandemic. Outside of my practice, though, I've been fortunate to be able to test face-to-face with children because of our kind of two office setup that we have here at NESCA. I know, in let's say a more remote location where virtual telehealth is really critical for access to a potential diagnosis, telehealth services, or during the pandemic when telehealth services, really became critical. The CARS would be an excellent modality that can be used for virtual testing, right? Where you're having a child and a caregiver engage in interaction together, and you're using a gold standard measure to rate and evaluate that interaction. So I wanted to show this bin with a bunch of toys in front of it is our combination of toys and activities that may or may not be used in the ADOS depending on a child's age. And all these toys are part of standardized assessment that has been looked at, researched, used frequently with children to evaluate, do they have this diagnosis or not? And so these toys are used in very methodical ways with children in a specific manner that an evaluator has to be trained to know how to do so, to press or pull some particular social interaction behaviors or behaviors that are sensory in nature, for example, that then are rated and evaluated in another rating scale by myself or an evaluator to determine if a child presents with a constellation of symptoms consistent with the diagnosis. As I mentioned, we are looking at how has the pandemic, as we know, for every child, every parent, every professional had really significant impact on all our social skills. So we have to take that into context. And we have to, again, as I was talking about earlier, really look at a child's functioning now with the pandemic and also pre-pandemic and what their life was prior to get a sense of what their social skills at baseline really look like. As I mentioned, diagnosis during a pandemic, we have used telehealth observation and assessment. Those are some others that have been used in the literature more frequently so that children, particularly in toddlerhood, can access the diagnosis early to receive access to services that are needed, like ABA, for example. And as I mentioned, this is a need or a time for flexibility, right? So, for example, when I'm looking at a child's social skills, perhaps now as compared to before the pandemic, this might be a time where I'm asking, parents to, send me videos or home movies or, or sending things from their iPhone so I can see what this child was like pre-pandemic and get a sense of what their skills are. So it's critical that there is some flexibility in an evaluator for how we look at these skills based on this context and what our pandemic has created in terms of our social skills, wearing masks, reading cues, as well as our emotional health, our stress level, sense of isolation. One of my core tenets that is consistent with how we understand the best practices for diagnosing autism spectrum disorder is that the diagnosis and making the diagnosis of autism spectrum disorder is not just about the test scores that you gather with the ADOS-2, the CARS-2, other assessments that may be used, parent report, teacher report. Those gold standard measures, for example, the ADOS-2 and the CARS-2, clearly state in their manual when you are a trained expert in delivering those interventions and delivering those assessments, that the evaluator at the end of the day must integrate that information with who that child is outside of that test. Parent report, teacher report, observation of that child at school. And so it's actually not true that in practice, one should be just using that score to say, like a blood test, does this child have autism or not? That is not how the diagnosis of autism works. It's definitely not a blood test. We are not there yet. And therefore, we want to make sure that test scores and a child's performance on any test, particularly in toddlerhood and preschool age, are integrated with who they are in the real world and their context at preschool, at daycare, at home, when you as a family go out and go to the grocery store, when you go to the playground, right? We want to understand what that child's behavior is like in those settings, in addition to what these test scores tell us. Real life skills and detailed history of what these skills look like now, what they looked like before, what they looked like before the pandemic, or what they looked like pre-other events in a child's life. The birth of a sibling, moving houses, other adjustments and changes, critical for making a diagnosis. All right, so now we're gonna move to interventions, and then we will have some time in about 5 minutes for questions related to what I've talked about today, and also other thoughts, as I said, on people's minds around diagnosis of autism, our current pandemic, our reality of what we're living now day to day, working with children as clinicians, perhaps in schools, in clinics, parents. So with that National Research Council, the NRC, that is our global, global meaning, I should be more specific, in the United States, our research authority in taking together all the findings from the literature and experts on that panel saying, this is what an assessment should look like for a child who may have this diagnosis. This is what intervention should look like based on our research. One of the core kind of products of that National Research Council of members and experts was that in the research, 20 to 25 hours per week of intervention is recommended for particularly young children, particularly toddler age up through preschool, as well as into early elementary school. That is hours of intervention across a child's home life and their school life. So if we think about children who are receiving services at school, that would be considered part of their 20 to 25 hours of what they're receiving to address the diagnosis and to address their needs. So that's an important marker and kind of a framework I use for when I work with families for how we kind of create the roadmap of what services should we be considering? Where should we be looking for those services? Is this at school, outside of school? What are some of the resources that exist? You know, is there funding for this service versus this through the state or not? My framework is how can we build up to that general time frame of knowing that that amount of hours of intervention has positive impact on a child's skill development and managing the challenges that are produced from that diagnosis of autism spectrum disorder. So I provided a bulleted list in terms of with this age group particularly, so toddler age and preschool age. Some of our common in Massachusetts, also some nearby states, some of our kind of typical helpful research-based interventions that may or may work for a child. One of my jobs is when I evaluate a child to think about, okay, these are all the possible interventions that may be helpful for this child and this family. Speech, OT, ABA, a zones of regulation group, right? A floor time, DIR floor time, dyadic intervention with their parent or their caregiver. One thing I think is very important is that I find as an evaluator that we have to be mindful of where we're putting our resources, families, and sending families to go for finding help and interventions, and not overloading the family, really prioritizing this is what's most important right now at this point in this child's development based on this assessment. What do you think about that? Let's talk about it. So I might be recommending for a child that, we really got to focus on speech and language development right now. This is at the forefront. And so if it's going to take us some time to access those in-home ABA services that we want to get on the wait list for and we want to start in the near future, I want to think about how can we look at having speech and language therapy for this child at school or in preschool, also outside of school, perhaps privately or through insurance, to have more hours of intervention delivered and focused on language, for example. And alternatively, I might say, ABA seems to be an important key need for this child right now. Here's why. Let's talk about it. Similarly, I've worked with families where starting with parent support and mitigating parent stress is really the priority and at the forefront. So making sure that that family may be connected with the ARCs, for example, in Massachusetts, or autism support centers, perhaps a CPAC, or special education advisory councils in local towns, making sure a family might have access to a therapist if that's helpful to kind of navigate parenting a child with autism. While this bulleted list, is an example of some of the combination of services that a child may receive or that I might recommend. It is frequently the case that at a child's developmental level and how they present in an assessment and evaluation, I, prioritize what are the important key areas of need at this juncture that we want to focus on. I have some resources here related to some of the topics that we covered today. And then with that presentation in mind, I have some information about the ASD Diagnostic Clinic here at NESCA, my contact information. After today, of course, feel free to always contact me via email if other questions pop up. And thank you all for your time and happy to answer questions.
Thanks, Renee. We do have a question. Do the teachers actually conduct the assessments before doing the IEP, or do they just do the IEP without the assessment based on the child's age or what they're presenting as?
Yeah, so I'm thinking about kind of cases I've had where when I see, let's say a child at this age, so bridging the gap kind of between toddlerhood into preschool age or turning 3, oftentimes that's when a child's first special education evaluation might occur. And so with this age group, it's common that a child I see might be being evaluated at the same time through the school district and myself, and we would be coordinating and collaborating of these are the measures I'm using, these are the tests that I'm administering, how are what's your battery of tests going to look like for the school district's end, and kind of making sure we're on the same page and coordinating and collaborating, where I'm getting information from the school team, they're getting information from me. And so there are many times that there might be a concurrent evaluation between my evaluation and the schools or for an IEP. And then there are also times where a child may not be in the process of receiving an evaluation or an IEP, and I would be the first evaluator or look at this child's skills. And that would also be doable and acceptable for me to gather information myself and then work with the family around, perhaps advocating that the parents consider a special education evaluation based on my results. So there's flexibility with the evaluation occurring when teachers are either working with the child when they have an IEP, when they're just going through the process of an evaluation, or when no special ed services are in existence yet.
Okay, and we've had a request to just flip back to the resources page again, if you could.
Oh, sure.
And we can make this presentation available to anybody who wants. If you just want to let me know, my email is jhauser@nesca-newton.com. Absolutely let me know either in the chat or Q&A, or definitely send an email after as well.
Great.
Any other questions this morning? Renee, do you know how often a diagnosis may be delayed if there is some sort of bilingual challenge, like a speech challenge? Is that a frequent occurrence?
Yeah, definitely. I think that probably in the past, maybe 5 years, there's been some more empirically validated kind of research articles that have been emerging in the literature where we're specifically looking at young children who do speak one or more languages, and we're having more clarity and kind of understanding that bilingual brains and multilingual brains may operate differently in some regards, but at the end of the day, the diagnosis of autism is still detectable and can still manifest in children who may be monolingual or bilingual or multilingual. similarly. And so, you know, I've definitely had cases where, for example, interventions are not delivered related to language because there's concern that, well, this child is learning 2 languages, and therefore, you know, that might make it more difficult for them to use 100 vocabulary words instead of 50 vocabulary words when they're using single word speech. And we know that in terms of language development and how the brain works and how people and children learn to use language, that the bilingual, multilingual process would not impact that. And so I always recommend that if there are, you know, concerns where we say, wow, you know, my child speaks Spanish and they are exposed to both English and Portuguese, and I'm worried they're not, you know, saying as much as I would expect, or very different than, you know, what I see in other children their age, to always consider an evaluation or to speak with an evaluator about language development, and also considering looking at services and kind of, you know, starting, you know, let's say speech and language therapy if that's a concern, even when children may have exposure to bilingual or multilingual households.
Great. And does NESCA offer any services to actually treat kids who are diagnosed, or is that all outside of NESCA?
Great question. So here at NESCA, we definitely have services that would be appropriate for children, particularly with this age group, toddlers and preschoolers, who may have a diagnosis of autism spectrum disorder. Those include occupational therapy, speech and language therapy services. We also have an educational consultant and have expert in working with schools and school delivery for children with autism spectrum disorders, parent consultation, guidance, support around parenting children with autism spectrum disorders as well.
Great. And I think so far those are the questions. If anybody else has anything last minute, please feel free to put it into the Q&A. And again, Renee is certainly available to answer any questions after the presentation as well. You know, feel free to reach out to either Renee or myself, and I will be sure that that gets answered.
Thank you all so much for your time, and have a great rest of your day.
Thanks, everyone. Take care. Oh. Okay. And I will be sure to get the presentation out to folks too. So
okay,
thank you
great.
so much for that request. Thank you.
Great.
Take care.
Bye.